Well, thank you very much, everyone, for coming back into the room. I am Anush. I'm Head of Advocacy and Policy at Orchid Project. And thank you again for being here today on a very late, night and a rainy day. We really appreciate it to be here for this really important conversation. For those who might not have been here for the first panel, just to remind that some of the content discussed here, it's going to be triggering potentially, so for anyone, and particularly for any survivors of any form of gender-based violence. So if at any moment you feel you need to breathe, to leave the room, please do so and come back at your own pace. And Fiona here, that I'm going to ask to up and wave. She's our safeguarding person. If you want to talk to her, please do know she's here. So thank you so much. In the first panel, we talked about what FGM is, why it's happening, its prevalence. We've touched a bit also on what we're going to talk about now, but that's normal. So in this panel, with these lovely ladies with me, very colorful, very bright on the stage, we're going to talk about slightly different but very interconnected kind of direction, and FGM as a sexual and reproductive health and rights and a justice issue. So Sean already mentioned a lot of statistics, but I want to remind us that 230 million women and girls in the world, and probably much more that we don't know about, are survivors of FGM. And I really want that number to sink in, because we are talking about a really large share of the population of women and girls in the world, but kind of to emphasize, it's 12% of the whole female population of reproductive age. So that's a quite significant number. And the reason I'm saying this is because we need to look at FGM as a global health emergency and a public health crisis because of the scale, because of the consequences, and that's why we're having this conversation about sexual reproductive health and rights. So maybe just to remind us that for many girls and women, the FGM doesn't really stop after the act itself, and its immediate, often severe consequences, and often lethal ones. And I probably will bring another data that recently University of Birmingham in the UK did a study, and according to the study they have done, every 12 minutes there is a girl who dies directly because of FGM. This is something we don't really talk enough about. But what I want to say is that after the act itself, the FGM will keep coming up in a woman's and a girl's life when she starts menstruating, when she goes to a GP, when woman has an appointment with a gynecologist, in smear tests, in childbirth, in pregnancy. So WHO recently has done a study, and it talks about that FGM survivors are at much higher risk of complications in childbirth. So roughly, the risk is doubling for FGM survivors compared to those who didn't have FGM in prolonged birth, obstetrics care, and hemorrhaging. And also they're much more at risk of going to emergency cesarean section. So in the same way as we talk about sexual reproductive health and rights as an issue of bodily autonomy, of dignity and consent, the same way we have to talk about FGM, about the same issues. So we will unpack that today, and also hopefully try to answer some of the questions around the role of health professionals and the health sector that we've heard in the first panel. So we have an amazing lineup of speakers today. I'm going to introduce them before I answer the question because they have really big accolades, so you're going to remember them afterwards. I'll introduce them one by one. But before we do that, I wanted to start us with grounding us in activism and lived experience, and start with our amazing Hoda Ali. So I'm going to look at, yes. Hoda is a FGMC safeguarding consultant and has been a well-known advocate and campaigner to end female genital mutilation for many years. Hoda is responsible for safeguarding and leading the different teams with her experience as a professional and a survivor. Hoda now works as an FGM safeguarding consultant, educator and facilitator for schools and the NHS. She is also an inspiration to so many of us. I probably would say also a fashion queen, so I have to appreciate that. Thank you so much, Hoda, as always, being here with us. Hoda, you work at the intersection of activism, lived experience, and safeguarding. Can you start us by telling us about your journey to become an advocate for ending FGM?
Shall I be using a microphone? I'm already loud, like I always say. Yes, I think for me it's something that closer to my heart. I was 7 years old when I experienced female genital mutilation with my younger sister. It was something we celebrate about. I thought every single woman on the world will have gone through female genital mutilation, because it wasn't something that we thought it just happened to certain community or certain countries. And from there, I was told I was a woman. The world is my oyster, because before we were cut also, when we go to school, children will say, well, you haven't had gudnin, which is in Somali, gudnin means circumcision. Circumcision in female is female genital mutilation. Again, terminology is really important. So when you're reading about FGMC, you will see this kind of terminology, but just knowing what it really is and the deepness of it. For me, it was, I got sick when I was 11 years old, just 3 years after I had FGM, and that was, my period was accumulating inside and it had nowhere to come out. I had type 3 FGM, and as you heard earlier, there are many different types, and type 3 is total and partial removal, depending on who's cutting as well, but it's total or partial removal of the clitoris, but total removal of the labia minora, labia majora. They pull your skin together, they stitch it all the way down until you have, I know you're going to talk about this. So I couldn't have my period. And from 11 years old till I was 17, I was in hospital, 2 different countries, 3 different countries, 2 different continents. So the first time I got sick was in Mogadishu. When I got sick, the war was happening. My dad found out that it was actually a period that was accumulating inside, and it was Italian doctor who really came to rescue me. And from there, I was in Mogadishu, I was in Djibouti, and then I ended up in Italy because they could not figure out why I couldn't have my period. And I ended up in Milan, in Italy, and the first time I had my period naturally, I was 17 years old. And when I saw my first time I had period, I actually thought I was dying, because I was like, why am I bleeding? Why is there blood on the bed, So moving forward, at the age of 20, just 21st birthday, I moved to England. All I wanted to do was become a nurse, because those nurses, when the war was happening in all those countries it was always the nurses that was really looking after me. And I thought, what can I do in the life? Like, just become a nurse so I can provide help and support to everyone else. And so that is how I become a health professional. Now I'm a former nurse. I have left the nursing community, and so I arrived in the UK at the age of 21, and then one day I was running up and down the stairs, as you do, and I couldn't stop bleeding. Then I ended up in intensive care unit again, because I was this time bleeding too much. So I want people to really understand, when we're talking about survivors, the different experiences. Every survivor of the 240 million women and girls we're talking about today have different experience. My experience is only the one I'm telling you. My sister, who was cut with me at the same time, don't have that experience. And from there, I met my husband. I got married. All I wanted to do was have children. And at the age of 30, and after many IVF, which I nearly died, because all the operations that I had just to get my period out, is in medical terms called adhesions. So I had so many adhesions, like I couldn't have proper smear tests or examination. If I do, I will always have infections, and those will lead me to having perfect infections. So it was always scary to really go to the doctors and see and the medical help I needed, but that's all I knew. I didn't know anything. I had a gynecologist since I was 11 years old, and being an older woman now, I realize not every woman always experience with gynecology. There are women who are so lucky enough never deal with gynecology, but I had one since I was 11 years old. And at the age of 37, at the age of 31, I was told I cannot have my own children. So IVF was out of the question. They told me I have to have either surrogate mother to become, to have a child, surrogacy or adoption. And then at the age of 37, I was diagnosed with menopause, which is something nobody talks about. And I tell you right now, those women in this room, menopause to me was the worst thing that has happened to me. Like, people would think you had FGM and you have all of this. No, listen, when I was going through, I was still young. I will come out the hospital, I heal, I go, I'm running. But menopause, it does something to your brain. Like, I feel like I was partying every single night and I never had a sleep. So that was a whole different thing, right? So that, to answer, my answers are long, but to answer your question is why I have become this person that I become. Because one, I wanted to become a nurse to make a difference, and I did that. I ended up working infectious diseases department in one of the hospitals in London. And earlier when I was asking you the question is, I remember being in this hospital, especially in sexual health clinic, and women would refer to us from the GP and from all different. But this woman was not even sexually active for like 10 years. So why are they in sexual health clinic? Right? So with the doctors will be like, and I was like, do you thought about FGM? Is this woman had FGM? And majority of these women actually had FGM. They have the symptoms of having FGM, the pelvic infection, the urine infection was also something they thought it was sexual health problem. And it wasn't. So what do I do with me and my long legs and my big mouth? I chased the chief executive around and I was like, we need to make a difference. I'm working in sexual health. I need make a difference for these women to have answers when they come to us. So I single-handedly train all the doctors, the nurses, the midwives, and then move on from one hospital to the other. And I'm talking about 16 years ago, okay? I'm a big girl now. And from there, I done the first sexual health performer that I added 4 questions into our performer. So any woman right now comes, especially, and again, it's a pick and choose. This is what I don't like, because not every hospital has adapted to this, but most of the hospital has now adapted part of their performer. Because when women come for help, especially in sexual health clinic, you're already asking them very serious questions, personal questions, right? So why not ask them the question? So we added 4. Have you had FGM? Yes or no? How many times? Type 4 to unknown. Then we have, do we need to refer this person to FGM clinic? And then we had an open space, the 4th one, to actually the medical professionals to write down. So in the future, if they've been asked that question, it's on their file. Because again, it's a trauma. You don't want to re-traumatizing your patient. Just make sure you ask the question as a medical professional and have those, and make sure that you read the notes. And also I'm the co-founder of the Favenges, which is a charity that I co-founded here in London. And again, it was to work with young people to educate them. And 7 years ago, I moved from nursing to education. So right now I teach in primary school children in year 3 to 6 how to keep themselves safe. I work with NSPCC. So if there's any mothers here, you will know about the pants rule, you know my body, my rules, and just moving from there.
Thank you so much, Hoda. I know you've lived many lives and you can talk so long about this. So thank you so much for sharing your personal experience as well. I know it's not easy. And maybe moving on to you already started talking about your role in safeguarding, and I think there was a question in the back, so I want to come to that. So from your...
That was your question, wasn't it?
Yeah.
Okay. We're told, obviously, by the head what to look out for, and we do that right across the spectrum for lots of reasons anyway. If a child has withdrawn, gone quiet, we would ask the parents, has anything happened, for example. But education is the answer. But like you were saying as well, it's making sure that the teachers can do their part in that, in the way they question and the way they try and, I think, make it. I mean, part of the education had that My Body. We did that 100% because it was all about being safe, making sure no one had access to your body without permission, and also what didn't feel normal or natural. We gave the language, we scripted it for children. No, that's my body. You cannot touch me. We made it very simple. It links, and that we didn't have a problem with. It links with anti-bullying and all of that. But how to move forward with what we can do in the community, going from the classroom, is a difficult one, I think.
Right. So I will.
Maybe I can add to that as well. Thank you so much for the reminding us of the question. And if we add here a bit, and I will ask you to try to wrap up the answer. If from the safeguarding perspective, what you want the audience to know is what does respectful encounter with a health professional look like? What they can do not to re-traumatize, not to re-trigger, and not to make survivors feel disempowered. So that's maybe if you can talk both from safeguarding perspective.
Okay, so let's talk about the health professional, and you guys gonna come in after. I think with health professional is that if you don't know something, it's really hard for you to provide that help and support you need. We don't have enough education for health professionals here in the UK. We have students leaving university as the doctors, nurses, midwives, and they've never been taught about FGM. They've been taught everything else, but not that. So how do you expect it that young man or young woman to come and take care of their patients without even knowing what am I looking at? I have been called many times to the in surgery or even in the sexual health clinic for doctors asking me, is this FGM? And I'm a nurse. You understand? So as a doctor, so I think knowledge is power. That's why I always say knowledge is power. The more we educate each other, the more we provide. And this goes back to our country, in our government. They need to put more funding to educate their health professionals to talk about female genital mutilation. We just don't have enough. And I really feel sorry for any new medical professionals coming into this professional, because there's already some of us out there that is still struggling, right? So I will leave that, and the other doctors sitting next to me can add to that. But when it comes to education in primary school, I think it's really important, because we need to think about how can we safeguard children and educate the parents and the community before this harmful practice happens to them, which is why I say power in education is power, right? Knowledge is power. What I did in the 8 years ago, I am the only person in the whole of the UK, including Scotland and Ireland, teaching children, working with parents and the whole primary schools about female genital mutilation or cutting. So what we do is the whole school staff training. Everyone have to have knowledge about FGM, what to look for, what is it. Then 5-parent workshop, including all safeguarding. There's no reason if you're working in primary school just to call your parents and say, I want to talk about FGM. No, let's put workshops together for safeguarding, including female genital mutilation. So we build that relationship with the parents. Reason being also, I only had one child pulled out of all of the 7 years from year 3 to 6 that was pulled out of my classes when I was teaching, because I work with the parents. Parents knew what I'm teaching their children. It is about the right time at the right age, and giving enough information that you need to do. So again, a lot of my work is online. You'll be able to see my reports that I do with schools and the parents and also the children. This is the most amazing thing. When children learn about how to keep themselves safe or how to keep themselves safe and look around their parents, I have amazing there was a young boy, year 6, who wrote a poem and a speech, and he ended up actually doing that at Sadiq Khan's office. I don't know. I don't like governments, but, So when you give children the power to understand and to keep themselves safe, they really do. So those of you who need anything you need, just contact me. I will send you all of my work so you will see the difference the children can make. And moving forward, they will speak for themselves, and nobody can make them do something they don't want to do, even if it's themselves or their friends. And knowledge is power.
Thank you so much, Hoda. That's a really powerful note to move on from knowledge is power, to move from individual experiences and lived experiences to move to frontline and have Dr. Aziza Sesay with us, working at the frontline as a GP, and I'm going to read your bio. So, Dr. Sesay, I know you told me don't call me that way, but that's your name on all of the YouTube videos. So, Dr. Aziza Sesay is a GP educator, honorary senior clinical lecturer, host, speaker, and health content creator. She runs a health platform called Talks with Dr. Sesay, sharing evidence-based health information on a variety of topics, specifically women's health, cancer awareness, and mental health. Yeah, that's fine. Okay, I know. There is a lot. There is a lot, and I would encourage you to look at her videos. And I know that you have to leave as well very soon, so apologies that we're keeping you here for a bit longer. So let me start with the question about the language, because it also came up, and Hoda mentioned it before. So within the FGM sector, we often talk about the importance of language, using the right language not to minimize or whitewash survivors' experiences. And we know, particularly in these days, that words are used as an instrument of power to silence or to mobilize, to humanize or dehumanize. So, and I know that you talk a lot about destigmatizing the shame in women's health in particular. So can you talk to us a bit more, and why is this important?
No, absolutely. So some people say that I'm obsessed with vulvas. I don't know if you guys would agree. I have a few. So actually, before we start, can I get everyone to shout out what this is, if that's okay? Yeah, on the count of 3. 1, 2, 3. Vulva. Yes, amazing. Let's get comfortable. I'm really big on destigmatizing and normalizing those words, because I feel like a lot of us have grown up with a lot of shame, stigma, and embarrassment. There's a lot of taboo surrounding it. And sadly, this is why conditions or practices like FGMC are rife, and why they continue, sadly. And also, there are so many people who don't even know that they've been cut. And that's a reality. I'm wearing this t-shirt. It's a not-for-profit t-shirt because I want you guys to shout out some more words. So what does it say at the front? Yeah, and what does it say at the back? Yes! There's a song. There's a dance. Everyone should do the dance. No, basically, last year we released this song to try again to normalize. It's it's catchy, it's an earworm. You can't get it out of your head, but it goes vulva, vagina, clitoris. Rewind it. And you just keep saying it over and over again. Kids love it. I don't know about their parents with them singing it. But ultimately, when we normalize the word, we empower ourselves, we empower our children. And especially because you said about children, the reason they need to use the correct terminology, and I'm saying the same for testicles and penis and so on, is because then we empower them with the knowledge. We give them the confidence of these parts of their bodies. We remove the shame and stigma. And it means that they also have that body safety. Right? Because, and sorry, this is trigger warning. There was a young girl who was taught to say cookie, because a lot of people say, oh, these words aren't very cute. Let's let them say all these weird and wonderful words. I had someone say moof moof once. I was like, what's that? Why can't we just say the correct terminology? When we use the wrong terminology, it causes confusion. A young girl was being molested by her uncle, and she kept saying, he's playing with my cookie. He keeps touching my cookie. And her mom didn't understand for a long time, so we empowered them. And we know that sexual predators and those who exploit young girls, they often avoid children who use the correct terminology because it's like, oh no, they've been taught about body safety. And they can learn quite early on. Because when we use euphemisms, for example, there was a mom who told me she felt empowered and she taught her son to say penis instead of ding dong. And he said, oh, that's great, Mom. So what's the real word for my elbow? Head, shoulders, knees and toes, and vagina and vulva and clitoris. Yes, those. We can say those words. They are not bad words, just like our head, shoulders, knees and toes. But the moment that we stigmatize it, that's the moment that we're teaching our children that it's something for them to be ashamed about. And I go back to my kids, they know the correct terminology. So when my daughter was in year 2, this is last year, she was talking about something with her friends and she said vulva, and her friends were like, oh, don't say that word, shh, that's a bad word. Say private parts instead. It's something that is passed on intergenerationally. And even me as an educator, as someone who's a real big advocate, my daughter was shamed in school, and she then got nervous because she was literally the only one who said the words, that she started saying private parts. And I had to, again, reinforce that it's okay, Amaya. And then the teacher told me that actually, you know what? We teach them in year 2. Why should we wait until they're 6, 7 years old to say the appropriate words? Also, why can't we empower them to learn the different parts of their anatomy? We've spoken about the different parts, and I'm gonna, because I know someone had, I don't know if she's left already, but let's talk about the mons pubis at the top, the fleshy bit that has hair. You can have hair if you want. There's nothing wrong with that. The labia majora, as they sometimes say, but I often say outer labia, because the moment we say labia majora, it makes it sound like that bit is supposed to be bigger than everywhere else. But actually, sometimes the inner labia, sometimes called labia minora, can be longer, and that's okay. These are little different models of what the inner labia can look like. It just varies. There's vulval diversity. It doesn't have to be perfectly symmetrical. And it doesn't have to be the same shade that you always see. My vulvas are always brown because mine's brown. So, and we don't get that representation, and representation matters. And then we move up to where they meet at the clitoral hood, and then the clitoris. The glans clitoris, as you mentioned. I'm going to use this prop because I think it's really cool. So that's everything on the outside, right? So remember I said that's the clitoral hood. That's the glans clitoris there. On the back, do you remember when Dr. Victoria said it's like an iceberg? That's what's on the front. This whole bit, let me take it out. This whole bit is on the back. And that's the bit that they usually cut with type 1. And then you move on, thank you so much. And then you move down to the vaginal opening. And I always stress vaginal opening, because some people say vagina, the vagina is on the inside. It has the word in it for you to remember. Karen Hobbs always says that. And then the perineum. My daughter can name all these different parts, and she's been able to name it since she was 5. So she could tell me, Mommy, my outer labia on my left side is itching or hurting or whatever. I have adults who don't know how to say those things. It's so important that we teach these things early and, again, normalize and remove the hypersexualization and the shame associated.
Maybe just if you have time, a quick question to follow up and ask, what can GPs do? Like, what the primary care providers can do to help break the barriers down for survivors, for patients? What is it that one thing, the most important thing that they can do to do that?
Yeah. I mean, we've said it so many times. Education is so key, because if you don't know and you don't know that you don't know, how are you going to manage a patient? It's something that I feel needs to be mandatory training. We are looking into mandatory training when it comes to specific aspects of women's health in general practice in general. Technically, it is mandatory, but I feel like you can get away. You can become a GP without doing as much women's health, but that should be mandatory, because ultimately we're 51% of the population. the Royal College of GP, one of my colleagues, Dr. Itunu, has set up this women's health special interest group. So again, that's another way that we're educating more and more of the GPs. And it shouldn't be that only if you do a specific diploma or course or so on that you will have the knowledge. It should be something that's blanket all around. And I feel like it should be 100% part of the safeguarding training. I know that they sort of touch on it sometimes, but they probably need to delve into that because we all have to do safeguarding at least level 3. And I think it's really important that we are very compassionate and kind in how we speak to patients and just believe them, listen to them, and allow them to have their grief and not be judgmental, because that's something I find a lot of. Sometimes maybe they feel well-meaning, but it can come across as judgmental. So, yeah, no, it's something, as I say, I try and educate my colleagues in that manner, and I'm hoping that through more of these sort of things. Your film was brilliant, by the way. Honestly, it was really touching. Having all these different mediums of raising the awareness to at least capture the attention of people, to pique their interest. So we're not, like you said, admiring the problem and glamorizing it and normalizing it. We are changing the narrative and saving lives, hopefully. Oh, really quickly, in my community, there are people who are scared to speak up about FGM. There was a lady called Kajiatu who 10 years ago in Sierra Leone, she was basically kidnapped, and because she was shouting about against female genital mutilation, they cut her and basically left her to die. Thankfully, the police found her. She's fine now. But people are scared, and I even have relatives who are saying to me, as he said, don't don't talk about it too much. This is our culture, it's our tradition, and we don't agree with it, but you could get in trouble. It's all political. It becomes political. But if we don't talk about it, who will? Yes. We need to be the voice for the next generation. It has to change. Kids are dying. Women are being impacted for years. You're incredible. But yeah, thank you.
Thank you so much, Aziza. I think one of the ways is we need more doctors like you. The GPs need to advocate within their system. They need to be also people who are opinion leaders, who are shaping this, who are demanding more training. And I think something that stays with me is when you talk about this is that recognizing is not about treating everyone the same. When we talk about equity, is about recognizing, and adapting your approach depending on who is in front of you. That brings the better outcomes for people, for survivors, for any patient really. Not treating everyone the same, but being able to understand and nuance and to listen and to provide a really survivor-centered approach. So thank you so much for sharing. Okay. Take a breath, everyone. So we are moving to Dr. Annabelle. Dr. Annabelle is an academic, doctor, activist and writer. Very, very rich bio. She's an NHS consultant in Sexual Reproductive Health, working in South London. She founded the charity of Reproductive Justice Initiative, formerly Decolonizing Contraception, which I really like, which aims to address health inequities and racial disparities. The Justice Initiative has been shortlisted for numerous awards, winning Grassroots Organization of the Year at the Sexual Health Awards in 2020. And I'll do one more thing from this very rich bio, and I say that Annabelle is also part-time PhD candidate at Harold Moody Scholar and King's College London, with her research focusing on experiences of Black women in Britain with long and acting reversible contraception. And I'll let you tell about your wonderful book afterwards yourself as well. So thank you so much, Annabelle, for being here today. You have been involved in launching the National FGM Support Clinic. Can you speak to us about your role in the launch and why these clinics are so important?
First of all, can I just say it's been a really wonderful 2 panels. It's very hard to speak after that. But yeah, so in terms of the national FGM clinics, for context, I think thanks for the bio and the introduction. I came to Sexual Reproductive Health and being a consultant through FGM work. So I started working on FGM in education, like Victoria, 18 years ago when I was a medical student. And that's what impassioned my whole and charged my whole sexual reproductive health journey. So it's the whole lens kind of with which I look at sexual reproductive health. So the national FGM clinics essentially were clinics, some of which existed already, but we also wanted to set up additional clinics. So in 2019, so it was definitely pre-pandemic, I was seconded for my sexual reproductive health registrar role. I trained in Leicester, so we probably have people in common. The fantastic FGM clinic there run by Cornelia Wysanders, great, and used some of the experience I learned my SRH training to go to Department of Health and Social Care to assist NHS England and DECA, who I think, on launching the clinics. And that shaped a lot of my view. First of all, lots of people will never get a taste of working as a civil servant or in government, which I did for 6 months. And people often ask, what radicalised you? Because my politics is quite radical now. And I would like that would do it. Working in government during Brexit will radicalise you. So my perspective, for which I look at healthcare is quite different in terms of I look at it very much through a socio-political lens. So some of the issues people have raised already is why do some health issues gain momentum? Why do others not gain momentum? And what political levers do people pull essentially for them to get on the agenda? And a few of the things, succinctly put, because we are running out of time, about the national FGM clinics. This was at the time during a Conservative government. It was on the agenda partly because there was an interest in violence against women and girls at the time. Why was there an appetite? Because of certain issues that certain politicians were, friends with certain people. It raises things up the political agenda, but it also makes people look good, right? Politicians like issues that make them look good. And unfortunately, as a sector in a space, sometimes it's hard because we're trying to ensure that issues get the attention they deserve, and we want the services like the national FGM clinics, but then it also gets embroiled in lots of political wrangling. So people want things to happen on a national level, but no one's necessarily thought about how they're going to fund long-term services. They want a pretty headline, they want a photo opportunity, and after that they're not necessarily, and I'm not saying that was all of the national FGM project story, but it taught me a lot about how to build sustainability and what we're willing to do to gain kind of like political currency and headlines and make sure that we get services. So in terms of the national FGM clinics, if you don't know what they are, I do think they're really important services. There are clinics that exist across the UK. A lot of them you can self-refer. If you go on NHS website, you can look for a national FGM clinic. Some of them run differently. They're either nurse-led or they're run by obstetricians or community sexual reproductive health consultants like myself. Some of the services they offer is sometimes just a chat, in terms of some people are not sure when I encounter them if they've been cut, the extent of the cutting, if the complications they are having are because of cutting or something else. Some people want treatment, and it's always often picked up in pregnancy. Some people are not sexually active or don't ever want to be pregnant, and they want treatment, sometimes defibrillation, where if you've got type 3 particularly, and the labia majora or minora sometimes have been sewn over, sometimes people want that undone for sexual activity, for also having discomfort, scarring, range of reasons, and it can be accessed sometimes through those pathways. So in a way, the success story in terms of, at least, I think they've gained a bit more knowledge and awareness, although I still think all of the things we've discussed, GPs and lots of primary services and frontline healthcare professionals don't know they exist. And then all of the things I discussed before in terms of why maybe they weren't as successful as potentially they could have been. I'll leave that there because I know we're short on time, and I think we might have to say goodbye to Aziza.
Do you want to? Yeah, okay. Yeah. So thank you so much, Annabelle. I think what it showed, we had a conversation before we walked into the room that it is amazing that we have NHS, that we have the health clinics, the FGM specific clinics, but it also shows us the mainstream health systems are not necessarily well equipped to deal with, to be able to provide the right service. So it's a good thing to have those, but we also have to make sure that when people go to the mainstream services, they can actually get the care, the trauma-informed, survivor-centered care that they need. So also it shows us that, what can happen when the right, there is a political will, there is the right funding, and how these centers can become really helpful. So thank you much for sharing that. And maybe final quick question to you, Annabelle, is where do you think FGM, if at all, falls through the cracks of the SRHR services?
So, yeah, quite a massive question to end on, but such a vitally important one. So there's a few things in terms of the how we think about SRH as a whole. So for context, I'm a community sexual reproductive health consultant. Loads of people don't know what a CSRH consultant is. So it used to be a subspecialty of obstetrics and gynecology. It became its own specialty in 2010, and none of Europe have it. But we have really small training numbers, so it's actually the most competitive specialty in the UK. So when I started training, there were 4 numbers in the whole country, and so I went to Leicester for my training. So first of all, this is a reflection of the issues we have in sexual reproductive health as a whole. So community gynecology. So when we're talking about menopause, when we're talking about miscarriage, when we're talking about premenstrual syndrome, all of these issues, yes, they're addressed in obstetrics and gynecology, but because of the waiting lists and the times, people want community gynecology, and FGM is one of those things, right? So I think often we're addressing issues in social, political isolation, right? And sectors don't talk to each other. And because I've gone this whole journey and I work in a lot of spaces, it's frustrating. I go and I'll talk at, like an endometriosis panel, or I'll go and talk at a menopause panel, or I'll go to a birth justice panel, and actually a lot of the issues are interconnected. So one of the ways that FGM falls through the cracks, honestly, is it's not holistically addressed. Even though the people that often encounter FGM, like myself, in a sexual health setting or a community gynae clinic, may have a holistic understanding, is often isolated out. So, you mentioned you went through a menopause that was bad and not a great experience for you, but often people are not asking people that have experienced FGM about their menopause, or maybe they have endometriosis, because you might have what you had in terms of a hematoculpus, so where the blood can't come out because you've had infibulation and you're having painful periods, but that person may also have endometriosis. And actually, we don't even have the research to say that might not predispose you to having endometriosis, because our research is so bad. So one of the issues really fundamentally is like the lack of connectedness between SRH sectors, which leads to silos of kind of research, silos of funding. And just to conclude, because I know we're short on time, you can say I'm deeply passionate about this topic. I think one of the things, honestly, we do need to step outside our silos, but it's also to recognise this is not necessarily the fault of people in the sector. SRH as a whole receives like only 2% of all research funding in medicine, which is a reflection of the wider kind of patriarchal structures that fuel FGM, FGC in the first place. Like, we don't get research funding. We're constantly pushing against the grain, and our services are fragmented. So I'll just end on, when you're thinking about FGM that spans sectors, right? Sexual health, your GP, the NHS, we are all funded differently, which the public don't understand, different purses of money. And so when we're trying to build a service and we're saying we need smears, we need psychologists, we need a scan service, we can't get all of those things easily under one umbrella. I'm building a clinic at the moment, or trying to build a service in Lewisham, the Arise Women's Clinic, in our sexual health service. We've got pilot funding, but a lot of the issues I'm facing is the red tape, basically, and it takes a lot of time. So I'll leave that there, sorry.
Thank you so much, Annabelle, for sharing it. Thank you so much for doing it so in such a short time frame. We could hear your passion, and I know all of our panelists could talk probably for hours about this, but I want to quickly wrap this up, because I know that it's quite late and people probably have a couple of questions, but I want to say how humble I am in your presence, and how constantly I'm inspired sitting on a panel with people like you, activists, survivors who have the courage to talk about this issue and also talk about it so many times that it's despite how painful it may be. So I'm really, really grateful to you. Thank you so much for being here today, for being so honest and open in this conversation. So thank you. So I know people are tired and it's quite late, so maybe we'll have one or two questions if anyone has specific questions. And I know Aziza needs to leave, so please don't feel, you can, yeah.
Well, I'll order my Uber and then I'll wait for you guys.
Yeah, that's fine. That's very efficient, very efficient.
I'm sorry, this is really reminding me of, I hope that doesn't burst open, because I had an issue. I was traveling and I had like condoms and vibrators in it. It was vibrating in the hold, so they had to stop the whole plane. They thought there was something. It was vibrators in the hold. It was absolutely, it was terrible.
Well, no electronics. You're not
Yeah.
We have them as keychains. I have some keychains if you want.
I hear ideas, not questions, but that's so ideas already. Any other question that there is in the back? Yes, I think.
Yeah, they're only £5 and they go towards funding menstrual health workshops in Sierra Leone. If you want, they're online.
Yeah.
And little pocket vulvas as well here. So, yeah, I'm obsessed, I guess.
Yeah.
Okay, so the data, the statistics, the lack of knowledge when it comes to professionals, the gaps when it comes to the multi-agency approach, when it comes to FGM, the lack of services such as reconstruction surgery. I'm just wondering what has contributed to all of that, since we're now in 2026 and nothing is improving.
So I think some of what I was trying to say was also trying to speak to your question actually really quickly, which is that I think we're talking about this issue kind of like sometimes in a socio-political vacuum, and the thing, there is a lot of other things fighting for attention. So like at the moment we've got the national see you honestly formidable. So wonderful, and like makes information so presentable. But I think we're trying to often speak about this issue in a social political vacuum, and there's so many issues vying for attention. So there was a period of time where FGM was very high on the political agenda for various reasons that we don't have time to go into. And at that moment, it was getting a lot more funding, a lot more column inches. Sometimes it was driving maybe the wrong type of activity, but you know, there was a window of opportunity. There's the Overton window of opportunity. And then when that falls away and falls out of, it's deprioritized, something else fills that gap, because there are multiple issues, right? And people only feel like they have so many things they can pay attention to. So you get a lot of progress. And we did get some progress in terms of services, building knowledge with healthcare professionals, initiatives. There was something else I didn't touch upon. I was trying to, we have it in diplomas and things, but we actually don't have a concrete pathway for training people to defibrillate, right? In terms of, that isn't a certified thing. So we have FGM clinics where people defibrillate, but like the standardization process like we have for numerous other procedures of that level within medicine doesn't exist. So I started a piece of work on it and it fell away because there was nobody to pick up that piece of work when I left that department, right? Like, who do I hand this to? I've got to go back to my clinical practice. I've done the groundwork. What are you going to do to facilitate that ongoing? And I was like, I need this resource. People can't give you the resource, right? So that's some of the issues there. There's the momentum, and also then there are pioneers, right? Like, I take up an issue, I run with it, and then you sometimes get exhausted and you want to hand the baton to someone else, and sometimes you have made someone behind you, but but there's not always. So yeah, there's a lot of that within this space, and also funding. And then also, just one last thing, global political structure, we've regressed actually. When it comes to violence against women and girls, we have regressed in the last 5 years globally. And that means something for FGM, right? We can't just be like, oh, there's all this like other sexual exploitation and issues happening. It shapes how people feel towards this issue, and it is a priority.
No, I think that was perfect. I probably wouldn't have said it anywhere near that. So, but I think it's important to remember that that's why the governments have the responsibility as duty bearers to do that. It's also on us to use the right language. How do we talk about FGM so they don't push it away into a corner? Oh, that's a tradition, that's a culture, that's not a priority. So talking about as a gender-based violence, as a sexual reproductive health and rights issue, and as a public health emergency really makes a difference, because we are vying for attention with other sectors. And that's why in the limited funding environment, the issue kind of puts in the corner and not gets enough attention. So. Thank you.
Also, I think our government have to be accountable.
Of course.
You know, we live one of the richest country in the world, and it doesn't seem like, right, when it comes to violence against women and girls, and FGM is not something, it's just from yesterday. We talked about this as survivors alone in the last 20 years, make documentaries chasing, you know, the government. You seen the cruel cut when Theresa May was the Home Secretary, and it is just not the forefront of any government. When they want your vote, they will ask you, like, we will do this, but the promise that they made, it never comes in. So it's important that we actually make accountable in our government, because right now they're not accountable, especially when it comes to FGM, which is why we're still talking about 2026.
Can I just add also to your point in terms of holding systems to account, and it also builds on something you said on the last panel, right, in terms of there are pockets of prevalence in the UK which would follow, you know, in terms of diverse populations, where people are practicing or where people have migrated to and so forth. And I think something that isn't looked at, and I've pushed my own faculty on this issue, is in terms of health providers, right? I purposely went to go work. So I work in Lewisham, right? And I work at what is a small hospital. I purposely went to go and work in Lewisham because the issues that affect the community in Lewisham are the issues that I wish to address. Health equity, racism in healthcare, these are all my priorities, and it's what I spent a lot of time on. So I went there. But I'm not going to lie to you that, say, going to work in that area is easy, because I am doing and running a service on a worse budget, and we get less donations than another part of the country with half our problems. We have a national health service, but we have a postcode lottery. And in terms of holding people to account, I don't think this is spoken enough of. Not only do we have a postcode lottery, we have a health professional lottery, right? People that can don't necessarily go to areas that can't. People don't do that. People that can like to go to shiny hospitals with money and funding. And it's not to say that the health professionals there are not perfectly competent, but pioneering people get frustrated with systems that don't work. And we actually have a brain drain to areas that have more problems, from my personal experience, which also means the services that we encounter where FGM is needed are probably not the most, how can I say, well-resourced services. I think that's an overlooked issue personally.
Thank you so much. And thank you again, Hoda and Annabelle, for being on the panel and talking so eloquently about the issues which are not easy to talk about. I'm going to hand over to Natalie to, I guess, usher us into...
Before you do that, can I just say, my daughter, absolutely, she's only 11 years old, by the way, but she has told me in my ear whilst you were talking to me, that she has loved this session, that she's loved hearing you guys tell your stories and educate. And like you said, Hoda, this is is very important for children to also be part of these conversations, because I can tell you, as a mother to a daughter, as a survivor, she is well educated, and she is educating her friends, educating her teacher. She's educating everyone. So give children the power to educate.
Well done to you,